Good evening, everyone. I'm Dr. Brad Schlaggar, pediatric neurologist and president and CEO of Kennedy Krieger Institute. It's my pleasure to welcome all of you to Exploring the Brain. From cell phones and wearables that track steps to artificial intelligence, technology has become an ever increasingly important part of medicine as it allows clinicians to deliver care in groundbreaking ways. Advances in technology are key to an approach to clinical care called precision medicine. This approach requires the gathering of a lot of data unique to a given person and then uses advanced methods like artificial intelligence on those data to identify the best individualized approach to clinical care for that person. Today, we're going to discuss a particular form of precision medicine known as precision neurorehabilitation. Here, neuro refers to the nature of our work of treating children, teenagers, and some adults with injuries or illnesses that affect the brain and spinal cord, that's the central nervous system. And rehabilitation refers to the therapies and interventions devised and implemented by our interdisciplinary teams, many of whom are national or global leaders in their respective fields. Our clinicians might use precision neurorehabilitation to create a focused therapy for greater mobility after a spinal cord injury, for example, or for an eased return to everyday activities for a child with long COVID. In this way, care becomes highly individualized. It's an exciting approach to the work, and our efforts in this space only continue to grow. Last year, for instance, Kennedy Krieger received a $6.25 million grant from the National Institutes of Health for a 5-year precision neurorehabilitation project. The grant, known as the P50 Center Grant, is among the NIH's most prestigious and competitive awards. In rehabilitation medicine, they are especially rare, and to receive this grant places us among a highly select group of institutions. So tonight you're going to hear about this project as well as other work that is happening in our Center for Movement Studies and our Pediatric post-COVID-19 Rehabilitation Clinic and in our Center for Brain Injury Recovery. We're excited to report on those frontier developments and the ways we are delivering bespoke, individualized care. And joining me for this discussion tonight are 5 of my exceptional colleagues, whom I will introduce momentarily. But first, a few housekeeping notes. Your video and audio will be muted during the webinar, so please use the Q&A feature if you have questions. That Q&A feature is likely located at the top of your Zoom window, might be at the bottom. Check it out, but you can click there and submit a question. We'll try to get to all of the questions during the Q&A period at the end of the expert panel discussion. This webinar is being recorded, but your identity won't be shown on the screen, nor will we identify who asks the Q&A questions. And then the planned panel discussion will be about 50 minutes, give or take, with a 20-minute discussion and question and answers at the end. So, without further ado, let's meet our panel. I'm going to introduce our panelists alphabetically. Dr. Amy Bastian, a physical therapist and neuroscientist, is Kennedy Krieger's Chief Science Officer. She is a professor of neuroscience, neurology, and physical medicine at the Johns Hopkins University School of Medicine. Dr. Mayo Hill is a pediatric physical therapist and biomedical engineer at the Center for Movement Studies. She's an assistant professor of physical medicine and rehabilitation at Johns Hopkins. Dr. Laura Malone, a pediatric neurologist and biomedical engineer, is the director of the Pediatric post-COVID-19 Rehabilitation Clinic and an associate professor of neurology and physical medicine and rehabilitation at Johns Hopkins. Dr. Ryan Remick, a neuroscientist, is the director of the Center for Movement Studies and an associate professor of physical medicine and rehabilitation at Johns Hopkins. And finally, Dr. Stacy Suskauer, a pediatric physiatrist, is the vice president of rehabilitation and co-director of the Center for Brain Injury Recovery at Kennedy Krieger, and she's a professor of physical medicine and rehabilitation, as well as of pediatrics at Johns Hopkins. And welcome to all of you, and thank you for taking part in our panel tonight. And first, let's talk a bit more about this term I introduced in the previous comments on precision neurorehabilitation. And when we began to use this language and approach at Kennedy Krieger, Stacy, let's kick it off with you.
Sure. Well, Brad, This is what we've always been about, is wanting to get the best treatment to the right child at the right time. And what you're going to hear more about is that's not only about developing the treatments, but really where we needed to start was how do we measure how a child is functioning and how they're making progress with rehabilitation. So when I came to the Institute about 2 decades ago, I had the opportunity to join my colleagues in validating and publishing what we call the Kennedy-Krieger scales. And these were really developed because the scales that existed for use in rehabilitation really weren't measuring precisely enough a child's change in functioning. And so we found we really needed to be able to describe, as children were making gains, say, in head control and trunk control, and not just the big gains, say, in how far somebody could walk. And so now we've been using these tools for some time, and others across the nation and world are using them. And now that we have a lot of data from these fine-grained, precise tools, we're really learning new things like how quickly a child can hold their head up for 30 seconds after admission to rehab tells us a lot about the kinds of progress we can expect that child to make over weeks and months. And so I think it really took that beginning to become more precise with how we talk about function in rehab in order to set the stage for where we are now. And of course, in the past 5 to 10 years, we have new computational methods. We can acquire so much more data, so much more often, and really analyze it quite quickly. And so now that is setting the stage for this new era of precision neurorehabilitation, along with technology just becoming more accessible. So now we're really able to start to think about how can we take brain-computer interface and bring it to the rehabilitation unit? How can we really start to customize non-invasive brain stimulation? And so now we're talking about a whole new level of precision neurorehabilitation.
Amy, let's take a step back and maybe you can comment on how this concept of precision neurorehabilitation and Stacy's comments, how does that fit in with our current model of patient care?
Well, thanks, Brad. So our current model is really twofold, although in the end, we're doing precision rehabilitation already in a way. And so let me start by saying one group of patients that we see are kids who have common disorders or conditions, something like ADHD. So many of you probably know 1 in 9 children is diagnosed with ADHD. And so we see a lot of children with ADHD. That's advantageous for us because then we see a whole lot of variety in these kids. So we understand through our experience what things might work for which kids. And that's the whole point of precision rehabilitation. But we also see the rare and the ultra rare conditions. Ultra rare conditions are 1 in 50,000. There are about 7,000 people in the US with ultra rare conditions. And then with rare conditions, it's about 200,000, whereas ADHD is about 9 million. So the scale of these rare diseases, even though they are so much less prevalent, there are a lot of them. And so we have developed a way of looking at these rare disorders, rare diseases, children who have these conditions, and understand the constellation of impairments, natural history. And by that, I mean how they're changing over time, how they're growing, how they are responding to rehab, what their family needs are. And the big thing that Stacy said is the whole name of the game here is to be able to take in all of those data and make a good prediction. And that prediction is what features of a child's condition is going to be sensitive to the kinds of interventions that we offer. This requires a lot of data and experience. We have been doing precision rehab or N=1 studies for quite a long time. And as I said, some of these conditions, even though they're rare in aggregate, they're very common. And so I really have enjoyed watching this new effort come online and understanding where we can go with this. One of the hardest things for us to actually be able to quantify, understand is rehab, exercise. That can be in the form of speech therapy, that can be in the form of physical therapy, occupational therapy, a whole host of sort of non-medical, non-invasive treatments. And what those treatments do is actually teach the brain new things. The brain changes with therapy. And so we want to understand doses and what kinds of things are the best for the children that we serve. So, summary, we've been doing this. Now we're going to do it in a much more formalized way. We're going to do it on steroids. We're going to make it really great.
So I think this is a good opportunity for us to go around the horn and each of you speak to how this approach intersects with your own work. And Amy, we'll stay with you for now. How this precision neurorehabilitation sensibility intersects with your work in a more specific way, Amy.
Yeah, my lab studies how people learn movement and how children learn movement. And it's not a single process. It's not one size fits all. There are lots of mechanisms in the brain that are actually involved in learning. And so we have tried to dissect or understand what is available to a child and what's not available to a child as we try to dissect all these learning mechanisms. And so the precision part is doing these kinds of tests and then saying, we need to treat them in this way because we know that there's a capability of a learning in that way. The other thing we're doing is stimulating the brain, and we want to know the right stimulation parameters, the location. It's not always intuitive. And so there's a lot of detail that goes into thinking about precision with motor control work like I do.
Nayo, you're up next.
Yes. So I'm really excited to be here and kind of share a little bit about what I'm doing. I focus a lot on the development of the tools, as both Stacy and Amy mentioned, the development of the tools that are really necessary for this really specific quantification of movement. My area of focus is individuals with cerebral palsy, so who have had an early disturbance to the developing brain and how that affects their movement and their motor control. And so I'm really focusing on developing tools that can be utilized before, during, and after physical therapy, intervention, and care so that we can really track patient progress, understand what is working, what might need to be fine-tuned, and really be able to augment what our clinicians are able to see via observation. So it's really about the data and the way that we can measure movement in a really specific and highly quantified way. And then another area that I'm focusing in on is really leveraging the electronic health record and understanding what has been done, what has worked for patients in the past, and utilizing the precision neurorehabilitation approach from the perspective of identifying groups of patient trajectories that might give us information on how we might be able to intervene for future patients based off of the wealth of data that we have on the patients that we have already served and treated in various ways. So it's really trying to utilize the data that we have to really specifically understand what might work for patients in the future who have similar types of features and characteristics of patients we've treated previously.
Laura, how about you in the post-COVID space?
Sure. So Brad, I work with, all these folks here in the Center for Movement Studies and also the Center for Brain Injury, and we look really at how typical development, as Amy mentioned, occurs in children. And then when there's an injury at different time points, what resources are available, what that recovery looks like in order to then maximize and optimize the recovery and function, because it's not always the same for every child. But you had referenced our long COVID work, and there we actually use precision rehabilitation as well. When we were one of the first pediatric long COVID clinics in the United States, And we were some of the first to actually describe what long COVID looked like in children. Very early on, a lot of the attention was on hospitalized adults and having these lingering effects. And we actually saw patients, young children that had mild infections that went on to develop post-acute problems and difficulties in their daily lives. And so it was a new presentation, a new clinical syndrome. And so we really had to use data and use our clinical practice over time in order to really identify what are the patterns that we're seeing. How then can we help inform other centers regarding how do we treat pediatric long COVID? And now we're really trying to understand, are there different causes or different mechanisms that might result in long COVID in one patient versus another? And so how can we identify that? How can we optimize those treatments for an individual patient? Because the presentation can be so varied.
Ryan, you're up next.
Thanks, Brad. Yeah, and I'm really happy to be here. This is just truly the work that I've always wanted to do. I grew up in a small town in rural Nebraska of about 8,000 people where you have to drive an hour to an hour and a half to see any sort of medical specialist. And in my career, I'd always wanted to do something that could be translated to a place like where I grew up. And so some of the keywords that really motivate my research have already been mentioned. Things like scalability, things like accessibility. My group is really focused on developing new technologies that can reach hopefully anybody. We'd like to have these technologies not only be far-reaching, but really easy to use so that you don't need a lot of technical training to be able to use them. For example, we'll talk about these later, but my group uses a lot of emerging AI and video-based technologies to do quantitative human movement assessment. We're interested in getting really precise measures about how well somebody can walk or how well they can move their hands and fingers. We're also interested in using things like commercially available wearable devices to track how much people are engaging in their communities and walking around on a daily basis. And when you do walk around, what happens to your heart rate? What happens to your physiological signals to give us some information about not only are you participating in the community, but how well is your body responding when you do participate? And then also, some of my core training is really in developing new ways of delivering walking rehabilitation. So we try to come up with really innovative ways using, again, readily accessible technologies to deliver new ways to help people to walk better. And I tend to work on, like most on this group, patients with different neurologic conditions, and most of my work ranges across the lifespan, from kids to, older adults with stroke, might be 90 years old. So yeah, glad to be here. Thanks.
And Stacy, back to you to round out this Around the Horn.
Thanks. And I'm going to take us back to the inpatient rehabilitation unit where we see children with a range of severity of brain injury, whether it be from a car accident or a terrible asthma attack and not enough oxygen getting to the brain. And the children with the most severe injuries who come to rehab may be in a coma-like state or what we call a disorder of consciousness. And we really do those kind of N=1 treatment for each patient. And we have been doing the people intent sort of low-tech precision rehabilitation of taking all of the assessments that neuropsychology and behavior psychology and the therapists do over the course of a week and map it out and look at how that intersects with our medication changes and whether the child is making gains or maybe falling a little bit behind where they were the week before. And now we're really set to go to the next level of precision rehabilitation and talk about new interventions, like Amy referenced, stimulating the brain and thinking about what do we know about each child's injury based on their MRI scan and the pathways that may be most accessible to, say, jump-starting parts of the brain that aren't activating on their own. And so it's just really exciting to start layering the precision neurorehabilitation.
I think all of your comments really reflect the depth and breadth of the opportunity that this approach offers. And as I mentioned in our introduction, Kennedy Krieger received this really significant grant from the National Institutes of Health last year for this groundbreaking 5-year project. Amy, can you tell us more about that project, what it means and what the structure of it is?
Yeah, sure, Brad. And I want to start by saying this is a team effort, and some of those team members are here. So I'll give you an overview of this. and point out some really interesting things about this particular kind of grant. It's called the Center Grant. And what that means is it's supposed to be a center that actually creates tools, methods to be able to disseminate to other centers in the country so that they can actually build a reasonable infrastructure for doing what we're calling precision rehab. This is a hard grant to get, and it took us a lot of time and a lot of effort. It's only one of 6 in the country, and we're the only one that focuses on pediatrics. So this is an exciting opportunity for us. We are approaching this in I think, a really sensible way that puts the patient first. So a lot of the time, a clinician might see a patient, a child, and they decide what they think they need to work on. We, at the very beginning of this process, our first goal is to talk to a lot of patients, a lot of caregivers, a lot of therapists, a lot of clinicians, and understand what they actually need. Sometimes those things don't line up perfectly. And this is a really, really critical process because we don't want to build something that's not going to actually address those problems. We are using technology to help measure, and I'll let others comment more on that. We are studying different kinds of patient groups in a staged way. Some of it is in person, and a lot of it is outside of the clinic. And so the real beauty of this grant is we're doing this, but we're also documenting. We are, all that information will be available to other centers. We want to help them replicate what we're doing. We're giving out small grants from our center to people who are interested in building these. And we want it to be generalizable, not just something very specific to Kennedy Krieger. I would say that handing it over to Ryan is actually probably a great idea here. So he can tell us more about technology because his area has really boosted this grant. So, Ryan?
Yeah, thanks, Amy. I'm happy to talk about that. As I mentioned, my group does a lot of work in technology development. As Amy also mentioned, the kind of core of all of this is team science. It has to be team science. It won't work in any other way. And so as part of that team science, all of our technology development is driven purely by interactions with clinicians. As Brad mentioned at the top, my training's in neuroscience and engineering. I learned very early on in my career that if you're going to do something impactful and that's actually going to spread out into the communities, like I mentioned, that I'm from, you have to listen to the clinicians who are working there. If you're going to put technology in their hands and you want it to be useful for their patients, you have to listen to what they want and what they need. And so as part of this precision rehabilitation approach, we've just talked to a ton of different clinicians at Kennedy Krieger, at Johns Hopkins, at many institutes, both nationally and internationally, to start to learn more about not only what types of technologies people want to facilitate these precision rehabilitation approaches, but what that form factor should be like. Maybe somebody wants something that will measure how well somebody walks, but does that need to be on a smartphone? Does that need to be in a mobile application? Does that need to be in a new clinical scale? And so by focusing on both what clinicians want and how we need to build those types of things, that has really, I think, put us ahead in terms of developing new technologies that are making it into the clinic. And I'm happy to share that a couple of the technologies that we'll talk about later, I think with Naya as well, have already been implemented in Kennedy Krieger clinics and are being used on a daily basis. And so again, focusing on that scalability, focusing on that accessibility have really been important keys for us. The last thing I thought was maybe worth mentioning at this point was we've talked a lot about kind of what precision medicine is, the core of precision medicine being focused on delivering the right care to the right patient at the right time. I thought it might also be helpful to talk about where precision rehabilitation is a little bit different from other areas of precision medicine. Precision medicine has been really developed in fields like cardiology, or cancer research, cancer clinical care, where, for example, you might be using information or data that you can gather from somebody's cells or from their genes to make predictions about their likelihood of having a particular diagnosis or a particular treatment path. Where rehabilitation is a little bit different than that is we focus on function. So we're focusing not on your cells and your genes, we're focusing on how well you can move, how well you can walk, how well you can talk, how well you can feed yourself. And so we're really interested in understanding specific features of human function that might put a person on a certain path versus another when we're trying to deliver that individualized care. And so in rehabilitation, again, we're all focused on function, and we really try to span what we call whole person function. So not only thinking about how well you can move, but also cognitive function, psychosocial function, really trying to address all these important areas that we know are important for a patient's recovery. Stacy, I didn't know if you wanted to add anything too.
I'll just add about how exciting it is to really work at that interface and help clinicians sort of articulate and visualize and bring to fruition their goals for their own clinic. So, for example, we're working with clinicians who treat children with cerebral palsy who are really at that stage of wanting to be able to gather fundamental data so that they can make sure that they are tailoring their treatment to what's important to that family and what we know works best at that stage of care. And in addition, while also, as Amy said, bring in what the family really wants and what the child really wants. And just to sort of reiterate that excitement of doing it here at Kennedy Krieger, but then really also scaffolding the process so that clinicians from any clinic, anywhere, will be able to really take our framework and repeat it with their own patients and their own providers. And so that the impact can just really multiply quite quickly.
Yeah, I think it's a great point just to underscore the importance of doing the work that makes it possible to disseminate for others to implement these what will become best practices for precision approaches to care. Great point. Ryan, let's go back to you. I think it's important to talk a bit more about artificial intelligence. Like, what is it at nuts and bolts, and then how is it being implied in your applied in your own work?
Yeah, artificial intelligence, or AI, as many of us know the abbreviation. The truth is the definition is getting broader every day. As new technologies come online, they're falling under this broader umbrella of artificial intelligence. I think I did a little bit of background earlier today looking at all the different definitions of artificial intelligence, and what the common threads seem to be. I'm not going to pretend like we're above anybody. We use artificial intelligence the same way other people do. We use ChatGPT to answer questions and help us learn things faster. But where we see the real opportunity in researching clinical care for artificial intelligence is in a couple of different areas. First, I'll talk about using it for data analysis. When we're talking about, as Nayo mentioned, and I think as Stacy mentioned too, using electronic health records, you're talking about using thousands, hundreds of thousands, millions of data points. And when we have all of that data, it's just not feasible for a human being to scroll through all of that and try to make sense of everything. So when you have these artificial intelligence models that can identify patterns in those data, identify specific subgroups of patients that might respond similarly to similar interventions or similar treatments, and those things can be done essentially at the blink of an eye, those technologies become very valuable and very impactful in allowing us to identify, like I said, those clinically relevant patterns in important subgroups that we can see and start to emerge from those data. One thing that we use artificial intelligence for a lot, and this is actually using a large language model like ChatGPT, instead of just asking or answering and asking questions, we also use ChatGPT actually to help us write computer programs and software. So these large language models are now able to fill the role, or not potentially fill the role, but execute some of the tasks that, for example, a computer engineer would do, writing code with you. And so whereas I used to in grad school and during my postdoc, I would spend many hours, many nights writing code to analyze our data or, try to work with these new emerging technologies that we're talking about. Now I can sit in front of ChatGPT and I can just start by saying, hey, I want to develop a new software program that takes in a video of somebody walking and gives me back their walking speed and their knee angles and their step lengths. And ChatGPT will not only walk me through how to do that, but it'll actually write the code and allow me to copy that code and use it and edit it on my own if I choose. The third thing that I'll talk about is, in addition to kind of the pattern recognition and the coding, and then some of the data analysis stuff that we talked about, is One area of artificial intelligence that I think we're using really well here at Kennedy Krieger is not only in data analysis, but creating new tools for actual data collection. And so we'll talk about this, I think, in a couple of questions. But for example, we have a three-dimensional motion capture lab at the Kennedy Krieger Institute. Many listening will probably be familiar with these, and even if you might not recognize the term that I used. These are big, large motion capture camera-based systems where if you've seen the kind of behind the scenes of how they make Avatar movies or Madden video games, where you might see somebody with a big black suit on that has a bunch of little reflective markers all over them, and they're walking or doing whatever they might be doing in these animated movies or games. We have the same type of technology that we use to get really high quality measurements of how well somebody can move. The downside of those technologies is you have to come to a really, prominent academic medical center to be able to have access to them. And even if you do, it's going to take us an hour and a half to 2 hours to be able to get a high quality gait analysis on you. So they're not very scalable, again, not very accessible. We've been working with some video-based technologies that we'll talk about that use artificial intelligence to automatically identify all of these same parts of your body that we're measuring with those markers, using only a simple digital video that can be recorded on a smartphone or a laptop computer. And so artificial intelligence in that way is actually gathering data for us. It's finding all those important data points in that video and extracting them and allowing us to use them. So it's a really exciting time to start thinking about using AI and starting to actually implement it in our research and clinical care. I could talk for a very long time about this, so I will stop here and allow others to chime in.
All right. So that's a great setup, actually. Nayo, I think we should talk about how can you use data from a cell phone, for example, to improve someone's gait?
Yeah, no, it's a really important question. And really what we do as therapists is we observe and we look at somebody's movement and we try to identify what might be contributing to an abnormal gait pattern or a pattern that we want to correct. And so one thing that we can do with the technology that Ryan's group has worked on and many others have worked on is actually take a video with a cell phone or a tablet that will give us laboratory grade motion analysis with just this single camera. And so that's a really neat opportunity to augment clinical observation, but give these tools to clinical providers in their clinic settings or out in the real community, so we can really understand what is going on in somebody's movement and improve it. Another really neat opportunity here is that we can really track movement over time. And so as somebody is going through their rehabilitation process, we can record video after video after video and use the key points, as Ryan mentioned, to really understand how somebody's movement pattern is changing or improving over time. And we're really getting objective, quantified data to really be able to understand what's going on and what's working and what we might need to adjust. So using a cell phone or a tablet to record a video really allows us to direct our care and the way that we are approaching improving somebody's movement or gait pattern.
Stacy, we talked about the center that you direct for brain injury recovery. Let's talk about how technology is used in the evaluation and treatment of patients who have concussions, a common reason to be seen in that center.
Sure. Well, as you know, Brad, a concussion is the mildest form of traumatic brain injury. And it's because it can be so mild that there's a lot of diagnostic challenge, right? So somebody gets hit on the field and not sure if their head just hurts because they had a direct hit versus if they have a concussion, right? Even the NFL now has whole procedures for specialists and pulling players out. And so this knowing, sort of detecting rapidly if somebody's had a concussion. Of course, we know if you have had a concussion, the most important thing is to come out of play so you don't get hit again. But it's not always clear. And so there's a lot of interest in using technology to identify or diagnose concussion. And this is, goes the range from force sensors and helmets or mouth guards to measures of, say, how fast the brain is processing information by looking at EEG waves. But this really remains a challenge because the effects are mild and each individual child is different, right? That's what we're talking about, is sort of the need for the right child at the right time. And in fact, two different children may require different forces to get a concussion. And even the same child's speed of brain processing may change from day to day, depending on how well they slept the night before, what medications they've taken, how much caffeine they've had. And so we're not yet at the point that we can sort of rapidly have a baseline measure that can be updated, say, each practice or each game, and then checked again after each hit. But that's certainly what people are moving towards. And so I think we're going to continue to see improvements on the diagnostic side. And then on the treatment side, Adrian Svingos at the Institute in our center is really doing some exciting work. Ryan mentioned how through his work, he has really developed tools for using Fitbit, smartwatches, on patients in the community to understand how much they're moving and how they're responding to that movement. And Adrian's finding that applying the same to youth concussion seems really helpful. So much in the same way that some children with COVID go on to have more difficulties afterwards in regulating their heart rate, in being able to tolerate long periods of standing, sometimes that also happens after concussion. But the symptoms of dizziness, of brain fog overlap with the symptoms of concussion. So again, it can be hard to know exactly what we're dealing with. But Adrian's finding that even with 1 week of Fitbit data, we are able to subdivide children into different groups of how much they're moving and how their heart rate responds to that movement. And that may really allow us to then deliver precision in the exercise regimens that we prescribe for them, which may really help speed recovery from concussion overall. She's also studying a form of really online brain games as the technology, as a way to use very precise and rapid presentation of stimuli in a game-like fashion to help athletes get better in terms of how quickly they can look across their environment and identify what's there. And so if an athlete is returning to play, that's one thing they need to be able to do well to not get injured again. And so she's showing that even athletes who seem to have recovered from concussion can certainly improve when they play this game. And we're working on understanding how that may impact whether or not they get injured when they return to play.
Laura, Stacy mentioned some aspects of long COVID that overlap symptomatically with concussion. Let's talk about the variety of symptoms and this really new diagnosis, as you pointed out earlier. And what are the ways it's being treated in your clinic, and how you're using this precision approach? Some more detail about how you're using this precision approach to get at the treatment approaches.
Yeah. It's a great question, and I think perfectly tied to Stacy's response as well, as there's a lot of overlap, which then makes us as sort of neurorehabilitation specialists think, well, could there be a common mechanism that actually underlies things like mild traumatic brain injury or concussion and long COVID? And it's interesting that two very different types of injury, one being a virus that most people completely recover from and have no problems afterwards, versus a mild head injury, can sometimes cause some of these same symptoms. And so regarding long COVID in particular, we see a lot of the same symptoms that Stacy was just talking about. We see fatigue, we can see headaches and other types of pain. Kids report a lot of brain fog or difficulty concentrating, doing their schoolwork. They can have this orthostatic intolerance that Stacy was talking about, where they have difficulty being upright for long periods of time, standing in lines, and so feel like they get dizzy and lightheaded and need to lie back down. But it really is the presentation, although we're starting to see some patterns, it can be varied from one child to the other. And again, it's the same virus. It's many times the same mild infection, a runny nose that they had for a day or two. And so, what is it that causes one person to completely recover from their COVID infection or multiple COVID infections, and then another go on to develop persistent symptoms? And so we are, in our clinical care, our treatment to long COVID, we really do an investigative deep dive into the symptoms and how they're impacting their daily lives, how it's impacting a child's ability to go to school or see their friends or play their sports, and really trying to develop these individualized or precise therapy plans for them. And early on, it was a little bit of trial and error in a way, borrowing some of our treatment approaches from things like concussion or POTS, postural orthostatic tachycardia syndrome. But over time, we started to learn sort of patterns of symptom profiles that we're seeing, and what those recovery trajectories look like. And so, we've done this in clinical practice. And as part of our clinic, we've done a great job of, everybody's talking about data and the quantities of data, of really trying to collect precise, repeatable measures of how kids are doing, what their symptoms are like. And so we're using that data now to really hone what we think about as phenotypes or groups of patients that might recover one way or another, or that might present in one way and require a different type of treatment. And so the exciting thing is that in our data, we're starting to see similar things to what we've sort of noticed patterns clinically. And I think that that's a really important point when we think about precision rehabilitation is, and others have mentioned this as well, it's about using the technology. But the technology alone is not enough. You need those clinical practitioners, you need the families, you need the patients themselves in order to help identify what is actually meaningful in that data and what might be extraneous or might point you in a different direction. And so that's what we really try and do in our clinic and in all of our research, which I think is a way to optimize care over time.
Great points, Laura. Now let's talk more about how technology is helping you to evaluate and treat really young children with cerebral palsy. The taking the technology to bring a much more patient-specific approach to care.
Yes, definitely. So, especially with individuals with cerebral palsy, there's an opportunity early on where the brain is really plastic and there's a lot of opportunity for improvement. And so, what I'm really focusing on and excited about is utilizing a game-based therapy system in order to deliver care early on to individuals with cerebral palsy. So there are a couple things that are a little bit challenging in the realm of early intervention or kind of this early time window where you're trying to intervene to kind of decrease secondary effects of cerebral palsy down the line or across the lifespan. So one challenge is engagement in therapy. And so sometimes young children, as many might know, have shorter attention spans, or there might be some behavioral challenges that are co-occurring with cerebral palsy. And so that can make it a little bit more difficult for a child to fully engage in the therapy that they are prescribed or that is recommended. Another challenge is having those really specific tools or measurements of movement that span the lifespan, but also that are really fine-tuned and able to detect subtle changes in movement, more so than just the grand, larger changes in movement that kind of larger scales are able to detect. And so what I'm working on is using a gamified system. It's called Pediatric, and it was really developed out of a collaboration between clinicians at Kennedy Krieger and engineering undergraduate students who came together with the clinical need and the technical expertise to design this touchscreen gamified system that allows us to deliver balance training and reaching practice to young children with cerebral palsy. And so this game is really neat in that it gives the clinician a lot of customization of the therapy environment. So the child is presented with bubbles that appear on the screen, and the therapist can choose how quickly those bubbles move, where they are presented on the screen, so they can really specifically tailor the environment to meet the needs and the goals of the child for that specific therapy session. There's also things embedded in the game that give the child some autonomy. So they get to choose the theme of the game or the prizes that come out of the bubbles. So that increases their engagement and it increases the buy-in and the excitement that they have for participating in therapy. And then as many have mentioned, as I've already mentioned, there's the data aspect. And so with this particular intervention, we're able to get really specific information on how the child is moving while they're playing the game, how quickly they're reaching to the bubble, which areas of the screen or the workspace they are more accurate in popping bubbles versus less accurate. And so that really gives us information on how we can progress the challenge and difficulty of the therapy session from session to session. And so with all of these different features, this type of gamified system is a really neat opportunity to deliver care as well as assess and measure a child's performance. And some of the newer things that I'm doing is actually adding in accelerometers on the child's wrists and on their trunk. So we're getting more information on how they're moving so that we can continue to tailor and augment their care and really start to understand the dose of therapy. As Amy mentioned on the beginning, we don't have a good way of quantifying dose in rehabilitation. And so that's another line of work that I'm excited to explore utilizing gamified therapy.
Great. Thanks, Nayo. So I think we have time for one final question before going to the Q&A, but this is a question that I want to go back around the horn again. Each of you comment on something you want the general public, this audience, to know about the work that you do, and we'll go in reverse order this time. Stacy, you're up first.
Thanks. I think one thing that you've heard from everybody today is the importance of research. And participating in research may mean going to the doctor and saying that it's okay to use your clinical data, meaning nothing else is going to change in terms of your care, but that it would be useful to use that data to combine with data from so many other patients to learn things. And I think just to sort of spread the word on, there are many different levels of research participation, and it can seem scary when you're not exactly sure what somebody's going to do with your data, but also just how fundamentally important it is and how much we truly do learn from research, and value and respect everybody who agrees to participate in some way.
Yeah, excellent point. Thanks, Stacy. Ryan.
I think my message would just be that, well, it's hard to follow up Stacy's message because I thought that was wonderful, but my message would be that we are really trying to get this out of the lab as soon as possible. And what I mean by that is these are not simply scientific curiosities for us. I think our whole team here really passionately believes in the mission of translating everything that we're able to find in the lab, all of the technologies that we're able to build, all of the information and results that we're able to uncover using things like electronic health record data and things that are already being gathered as part of clinical care, using all of that to really start to inform how clinical care should be delivered to optimize the impact on the patient in a positive way is really what we're all trying to do. So we were talking a lot about research. We're talking a lot about different types of data gathering and all these types of things, but we're really trying to move this out of the lab and translate it into the clinic and real world as quickly as we can, while of course, maintaining quality standards and robust science and things like that we're all, readily aware of. But really trying to do this in a way that will be impactful for patients and their families.
Great. Agreed. Laura.
Yeah, I think those were both great points. The thing I would highlight, which I think that those of us on this webinar sort of talk about without always highlighting, but many of the patient populations that we work with are children. And so children are not just little adults. And so at the beginning of the webinar, Amy and Brad talked about how this grant that Kennedy Krieger has received is the only pediatric grant of all the centers that were funded. And that's a unique thing because there is some complexity in doing research and treating children because we're not dealing with a stable nervous system. There's ongoing development. And so it makes it harder to research, but we can't just apply adult principles and adult research studies to our pediatric populations. And so I think all of us and everyone at Kennedy Krieger sort of dug in on saying, this is a really difficult thing to do, but it's really worthwhile. And it might take us a little bit longer because it's more challenging, but we're really passionate about it. And it's so important. And so we want to lead the charge to be able to do that. And I think everyone here is so invested in that type of mission. And so just wanted to sort of bring that up as a unique part of our program that is not always everywhere else.
It's a great point again, Laura. So just to underscore that, we see patients at Kennedy Krieger across the lifespan, but we are definitely a pediatric focused organization as well. And in part, it's really critical that we are in that space because of what you just mentioned. Like, of the 6 center grants that are out there, we're the only pediatric focused. We need to hold space for the importance of developmental trajectories, that children are not just little adults. We have to understand how development interacts with injury and disorders and diseases, and also the rehabilitation that goes along with the interventions that are necessary. So thank you for underscoring that one too. That's a tough one to follow. Nayo, you're next.
Yes, no, I think that what you just said, Laura, is so critically important. I think one other thing that I will add is just the essentialness of multidisciplinary teams, both the clinical providers as well as research teams. And so all the things that I've talked about and all the work that I am working on currently have come out of partnerships between clinical providers, engineers, neuroscientists, all people who have different disciplines and expertise, but working together to really solve these critical challenges of movement and clinical care for pediatric patients and pediatric population. So it's just so.
Oh, I think Nayo froze, so we will pick up from there. And Amy, can you take it from Nayo?
I can. So what I want everybody to take away from this or remember from my piece is, Nayo, we're going to come back to you. Is that rehab is not just gaining strength, becoming cardiovascularly fit. People, we need to understand that rehab and experience is the only way that the brain is plastic. It can change its own connections and functions. Experience. Rehab is tailored experience to try to shape it in the right direction. But if you think about it right now, I will tell you that you are gaining and losing connections in your brain as I'm speaking to you. It doesn't matter if you're a child or adult, it happens fast. And the reason you're going to remember all of this terrific stuff that our colleagues have shared with you is because your brain is remodeling right now. It's forming memories, and that is part of experience-dependent learning, plasticity, and rehab is the way that we drive that. So many times a drug will make you better in some situations. A robot may, or some kind of device may help you. We can put new cells in sometimes. But if you want to change the way that people are able to move, to talk, to understand, it requires rehab. It requires experience. And I want everybody to remember that, because it's a super powerful way of treating people, and it happens naturally with the nervous system. And Nayo, I would love to pass it back to you to let you continue, but don't forget rehab.
Great. I'm so sorry about that. Yes. And that's wonderful comments, Amy. So I guess I don't know where I cut off, but I just wanted to reiterate the real critical importance of interdisciplinary teams. And that's really the message that I wanted to bring across, because as everyone here has mentioned, we're really focusing on a pediatric population that is dynamic and complex, and we really need to have our engineers and our clinical providers and our scientists from all different vantage points working together for these patients that have needs that we can address from our research and from our clinical experience. And so, I just wanted to leave with that message of underscoring the importance of our multidisciplinary teams.
Can I pick up on that as well, Nayo, that this is just really a principle for this institute of how we approach patient care, because we are dealing, as Amy is pointing out, really complex care situations. It requires the interdisciplinary approach that comes from the expertise of multiple types of disciplines, not one at a time, but converging on a patient and their family. So I think that's a great place to wrap this discussion. I know that there's a ton of questions starting to line up. And Amy, your last point addresses one of the questions that has come in already. And I think we can have others chime in on this as well. But the question from our audience member is, how does therapy actually change the brain? So you're commenting on that already, and I think we can pick up on that some more, but I think others would love to have a crack at that very important question.
Well, I'll start just by saying early in life, the brain wires up and connects heavily from one neuron to another. And what you end up doing with your body, with your mind, thinking, feeling, walking, smelling, all of these things, when you use those circuits in the brain, they actually stick. And the way they stick is that there are special trophic factors that keep those circuits intact, doing well. And so when you have a behavior that you do again and again, or even a one-time thing, those connections between neurons are just increasing. And that allows you to be able to process and save that information much more. So I will open it up to others who want to comment. I could talk all day, but nobody wants that.
Amy, when you were talking, I was thinking about, as a rehabilitation physician, I think my goal and the goal of working together as a team is to think about how do we help a child get the most out of that therapy experience. And so we've talked about brain stimulation. There may be medications that we hope will help recruit more of the brain tissue to be involved and sort of help us lay down some tracks the way we want them to lay down. We may be wanting to help control muscle tone so that it is easier to move through a more typical walking pattern, so that pattern can be ingrained and sort of carried over by the brain. And so I think it's sort of exciting to be able to think of the whole person, right? And how we work together as a team to make sure that the brain is getting the most of what we wanted to get out of therapy.
Yes, and a point is that the brain learns whether you're doing something good for yourself or bad for yourself. So you can have maladaptive plasticity. I certainly do with my posture. I keep trying to sit up straight, but the brain is constantly learning. And so those are the reasons that what we do in rehabilitation is really powerful. And if anybody else wants to make a comment, I will mute.
Others on the topic of how therapy actually changes the brain. All right, well, it's a great question, and it really sets up some additional questions for discussion. For example, what has been Kennedy Krieger's experience with transcranial magnetic stimulation? Are there any novel expectations? Ryan, you want to take the first crack at that one?
Sure. So for people who aren't aware of what transcranial magnetic stimulation is, it's a non-invasive brain stimulation procedure that applies a magnetic pulse somewhere over the area of your brain that we call your motor cortex. Your motor cortex is a brain structure that's responsible for a lot of your volitional movement, or the movements that you make on purpose. And depending on where you deliver this stimulation over that motor cortex, you can elicit small movements at different areas of the body. So, for example, one of the most common things that we do if we're assessing hand function using a TMS device is we might stimulate the area over your brain that makes your finger go like this, just this little twitch in your finger. And so by delivering that stimulation, number one, we can see whether that twitch exists once we stimulate that area of your brain. If it doesn't, then we know that you have an issue with what we call your corticospinal tract, or in other words, cortico meaning cortex, that area that we stimulated over, spinal obviously meaning your spinal cord. If you don't see that motor response, then we know that the area that was stimulated did not reach down to your spinal cord and out to your periphery or out to your muscles. And so that's one way that we can use this to look at, well, again, the integrity of that tract. The second thing that we can look at, or a second thing that I should say, is if we do see that twitch, we can measure the time between when that pulse was delivered and when we observed that twitch in your finger afterwards. And depending on how long that delay is between when the pulse was delivered and when we see that motor response, that can also give us information about the integrity of that corticospinal tract. It doesn't have to be all or nothing. It can be, there might be partial damage. There might be damage in one area that's slowing down that transmission. And one thing that I think we do well is by not only leveraging these technologies to study that central nervous system function, but we can pair them with some of the interventions we do. And so, for example, we can do treadmill-based gait training on a child with cerebral palsy. We can not only measure how well they can walk before and afterwards, but we can take those measurements of their nervous system using transcranial magnetic stimulation and see whether any changes from those stimulation parameters might have changed before or after the treadmill training that child did. And so what I always say is, like, it's great to know what works, but it's really, really, really critical to know why it worked. And I think that's kind of a central theme behind all of this precision rehab stuff, is we want to know why something works so that we know why it might work for the specific patient in front of us or not. And so anyway, others have used a lot of TMS here too. I'll hang up there.
Go ahead, Stacy.
That was great, Ryan, and really talking about that evaluation stage and how TMS is a tool for us to understand what's happening in the brain. And we're really just on the precipice of thinking now, how do we use TMS as a treatment tool also? Some in the audience may know that TMS has been approved for treatment of depression and some other psychiatric diagnoses. And I think is a really important tool for us to have in our tool chest, because we see complicated children and young adults and adults who maybe having medications and side effects are a challenge, or aren't responding to medications the way we expect they would. And so having a next line of treatment is something that we're really excited about. And in the future, hopefully we'll also move to maybe more novel uses in more physical and cognitive rehabilitation. So we know that what TMS does is really help cells fire, right? So we can use that to evaluate how the cells in the brain connect throughout the body. But again, as we think about different tools we may have in our tool chest to help activate regions of brain that maybe aren't activating optimally or have been disconnected from sort of their typical pathway, we're excited to think about how TMS, or transcranial direct current stimulation, DCS, can be used to sort of to work together with therapy to, again, sort of get the most out of therapy and engage the brain in the way that we want to engage it.
Any other takers on the TMS question?
Yeah, I was just going to add to Stacy's point. She talked about how TMS can sometimes recruit or activate certain areas of the brain, but it can also be used to decrease activity of certain parts of the brain that might be interfering with the ability to function, or the ability of an area of the brain to recover that you're really trying to promote activity and sort of learning in. And so it's a really nice tool because you can use it in different ways, in different situations, sometimes trying to increase activity of areas that you want to work more, then also decreasing activity of other areas that might be overcompensating, that might be interfering with therapies.
I have a quick last word on that.
Please, Amy, go ahead. Yeah.
One thing to be really clear about, these brain stimulation, external brain stimulation methods are, it takes time to have the effects actually give you a permanent or quasi-permanent change. And so you have to build them up over time. And so we're really just launching a lot of these initiatives. So it's not just stimulating the brain and you're done. It's very complicated, stimulating and using a window of opportunity where the brain's more excited or less excited to help with an intervention that you're delivering. It could be speech therapy, it could be physical therapy. So stay tuned.
So here's I'm going to merge a couple of questions that have to do with the understanding what clinicians want and how to make sure clinicians are aware of the work that's being done. So when you talk to clinicians, what are the types of technology that they want, and how do you reach clinicians across the country to find out to help them find out the work that you're doing so that they could use that information in their own practices? To talk about that communication and readout of the needs and wants of clinicians around the country. And I think
Ryan is a good person to.
Yeah, Ryan, why don't you take the first crack?
Yeah, I'd love to. I mean, this is one of my favorite parts of my job, honestly, is having these types of interactions to really understand the need. We've done a lot of stuff just like we're doing right now, talking on webinars. If you search for us, we have some YouTube tutorials up. We have some different kind of walkthroughs of our software available. Importantly, we are really, I think pretty much everybody on this call is really passionate advocates of open science. And so all the technologies that we develop, we try to make them free for everybody to use. And so if something's free, more people are likely to use it, and we can start having more and more clinicians using it and getting more and more feedback that way. We've also done a few things through some kind of pre-startup accelerator programs here at Kennedy Krieger Institute and with Johns Hopkins to get involved in things like doing what we call customer interviews, but in our case, it's really interviews with clinicians or end users for these technologies. And so we start to just gather as much information as possible, just by talking to people and asking them questions. And after you do it a few times, you start to notice some themes emerging, and you can do some qualitative type of approaches to start to identify what are the most kind of common requests or most kind of common questions that people have. If there's any engineers listening here who are developing rehab technologies or other clinical technologies, I would strongly recommend going into clinics and observing the workflows, figuring out how these technologies are going to be integrated into those workflows with minimal disruption to standard clinical care. Leverage technologies that are already in that space rather than forcing a new technology into that space. Think about how these technologies are going to interact with the patient, whether they're going to make the patient comfortable, whether they're going to provide useful data not only to the clinician, but potentially to the patient. And listen to what the clinicians think is really important about the technologies. I'll give an example. One thing with our video-based work that Nia was talking about, coming from a really, measurement kind of heavy background, we want to be able to measure all these like fine characteristics of somebody's movement. One of the themes that really started to emerge from the clinicians is that the granular movement assessments are really great, but what we really want to be able to do is use that as documentation over time. And so we can get these same repeated measurements over and over of these various aspects of motor function and then document them in the electronic health record so that we can track these patients more accurately over time. But yeah, at the end of the day, it's just start to develop networks, take advantage of any clinical shadowing or interactive opportunities you might have, especially if you're somebody on the technical side like me, an engineer, neuroscientist type of person. And then just listen. I mean, that's the biggest thing is just ask a question and be quiet and let the clinician tell you what they want.
That's great. This next question, again, I'm merging some, Nayo and perhaps Laura to take it on. So it's based on the idea that I think this might be a peer who's asking this question. In clinical practice, we're increasingly seeing genetic conditions presenting as cerebral palsy. Or put another way, patients with cerebral palsy increasingly we're recognizing have deleterious genetic variants as the likely etiology or contributing to the etiology of the cerebral palsy. So this question asker makes the point that while we've always managed these children in rehabilitation settings, our traditional approach has been really broad and not precise. So under precise rehabilitation, should we view this as moving toward more individualized goal setting, where we have a greater handle on the exact dosage and direction? So Nayo, for each child, so Nayo, and then perhaps Laura, but Nayo first.
Yeah. Yeah, that's a really good question. And yeah, a big kind of change in the field of cerebral palsy is kind of thinking about how these genetic presentations are distinct or similar to kind of the previous definitions of cerebral palsy. I think one opportunity here is really to look more individualized. So really trying to understand how the patient is presenting, which is basically what we're doing from the beginning, but really more focusing in on that and setting specific goals for the patient based upon their movement presentation. So it might not necessarily be the same categories that we have traditionally used and thought of in kind of characterizing the phenotype of cerebral palsy or kind of the movement presentation that we see in specific buckets, but there might be more buckets that are kind of emerging so that we really do need to fine tune our approaches to the patient that is presented in front of us. And so really thinking more about what the patient's goals and needs, what the family wants, and then the clinical expertise in terms of the movement presentation that's in front of us. So I do think that this is moving the field of cerebral palsy rehabilitation into more individualized care. Laura, do you have anything from a neurology perspective?
Yeah, I completely agree with everything that you had said, Nayo, and would just add, I think that this is a really great example of how precision medicine in general, but then also precision rehabilitation can really help us tease apart some of the differences. Is there a different trajectory for one child that has a genetic cause of cerebral palsy versus another child that has a more traditional sort of early brain injury, the way that we think about more traditionally being cerebral palsy? And so not only are those trajectories the same or different, but then also do they need, as you had mentioned, different interventions at different time periods? Do they need less therapy over time, or do they need more therapy in order to maximize maybe while they have some particular window of neuroplasticity or ability of their body to, recover function, for example? And all of that over time can be teased apart using these precision neurorehabilitation and precision medicine approaches. And so sometimes having that early identifier of this is at least a different characteristic for this patient compared to this other one, we can then follow those patients over time and say, are they similar or are they different, to then inform what we do for other patients down the line.
Stacy, question for you. How are clinicians being trained to balance data-driven medicine with the emotional and human needs of patients and families? Sort of a comment on the richness of data that can be used to be capitalized upon by artificial intelligence, but at the same time, the need for clinicians to show up as humans in their interaction, not artificial intelligence, but natural intelligence and empathy.
Yeah, I mean, I certainly believe that it still takes a human to understand specific child factors, family factors, to vary how information is given or obtained in the moment. And I think that is a focus of training. And at the same time, how do we use our tools in the moment? I'm sort of the thing that always comes to my mind is I have a medical student or a resident with me, and they know, right? So much can be found on the internet. They're often asking ChatGPT something in the room on their phone, and I think they're like texting somebody. And so trying to explain, even to the family, sort of what's happening in real time about, use of tools to optimize their care, while also maintaining that sort of human touch and the connection and not letting that go. So I think, right, that's why we call it the art of medicine to some extent. And I certainly hope that AI doesn't attempt to replace us from that perspective, while continuing to allow us to be most efficient and, both in terms of efficient with understanding a family's needs and communicating what we think will be most useful to them.
Yeah, it's an excellent question, well framed. Anybody else like to take that on? We are a training environment. I should say that our audience may not know, but every year over 1,000 clinical professionals come through our doors in all of the disciplines represented by those on the panel tonight, but many others. So this is a really important question for the Kennedy Krieger Institute overall. Others who want to take it on?
I'll
Amy. Yeah.
Yeah, I'll say something. Actually, many of the people that we are training are very aware and worried about that. They typically didn't get into medicine or therapy to offload most of what they do or some of what they do to artificial intelligence. And so I think our goal is to teach people how to use these things as a tool, not as a substitute for the creative intellectual abilities that humans only possess at this point. And frankly, also to just to help take away some of the repetitive things that are less about being with the patient and more about just, filling out this insurance document or that paperwork. Not that those are essential too, believe me. But I think that it's a new world. And so the way that we integrate these things continues to be a moving target, and it's important, and people talk about it a lot. But the main thing that people coming to Kennedy Krieger learn very quickly is that empathy and care and listening and really thinking hard about the families is the most important thing.
Here's a question about technology development. Do you or other physicians or clinicians, I'll say, work with companies to make technology that you can use? For example, will we have one day a Fitbit or a remote monitoring kind of device that has perhaps everything a doctor needs to track to help us stay healthy? What kinds of activities do we have, or any of you panelists have, in working with companies for such technology development? And I think Ryan and Nayo, you could speak to this, but others as well. Ryan?
Yeah, sure. So I mentioned, our preference is to make all of our technology that we develop freely available via open source sharing. However, we also acknowledge that if we're trying, it's kind of a paradox. If you're trying to make something scalable, you need to have it be scalable. And so in that way, to really scale up some of our stuff, we do have a partnership with a startup in Baltimore that has licensed some of the video-based gait and assessment tools that we have developed, and they're working to scale those out into a clinical product that could be used broadly. What was the second part, Brad, after the industry partnerships?
Well, can we get to a point where their insight?
Yeah. I mean, right now, I'm wearing a Garmin watch right now, and these things can tell you everything about your sleep, your heart rate variability, your heart rate during the day, the number of steps you take, the amount of time you spend in 5 different exercise zones. I mean, it's pretty comprehensive. To say that it's going to give your doctor everything that they need to monitor your health, I don't know about that. The bigger problem is when you have so much of this data, you have to sift through the noise and figure out what the signal is. So you need to figure out which of these different metrics that are available on that watch are most important for a person's health. And going back to the theme of the precision rehab stuff that we've been talking about, what's most important for a person's health will almost certainly depend on who that person is and what kind of clinical condition they may or may not have. And so I don't think it's necessarily about capturing everything that somebody's doing, but really being able to extract the most important information about how well somebody's doing. and then be able to manage that data.
Yeah. Naya, did you want to comment as well?
Yeah, I don't have a ton to add, but I think that that's a really good point of thinking about, what technology is out there and available, and how can we use it in a smart way in the clinic if we're not necessarily changing or developing something new, but using it in a novel way. And so making sure that we're able to extract the data we need from kind of commercially available wearable sensors might be an approach. With the Pediatric system and some of the other things that I've been working on, those are things that are meeting a clinical need that's not being met by commercial technology as it is now. And so thinking about how we can either partner with industry providers to change or improve or add features to some of the technology that might be available. So I think that there's a couple different things, like utilizing what is there, but then kind of thinking about what modifications might be needed for technology to be able to meet the needs that clinical providers have.
Stacy, a couple of questions related to concussion. So one is, you'd made the point earlier that after a concussion, first most important thing to do for an athlete or a recreational participant is to get out of the way of potentially getting injured again. So I think just, why is that the case? And then a related question about concussion is, what have we learned about the long-term recovery after concussion in children?
These are still really important questions. Certainly, why is it important to come out of play if you might have a concussion? We know that repeated hits can absolutely make a concussion more severe. So more commonly, what we see is a child who probably had several hits in a game, and for example, they had a headache at halftime, but nobody really thought much about it. They went back to continue to play, and then maybe it takes them weeks to recover from that concussion. The headaches are more severe than maybe they would have been if it had been recognized immediately and the child pulled out of the game. Fortunately, much more rare is what we call second hit syndrome. And this is where there can be a devastating brain injury when a child has another hit while they're still recovering. We think there's something special in the adolescent to young adult range when this happens, and it's really a catastrophic swelling of the brain, thought to be the result of a repetitive injury when the brain hasn't healed yet. And unfortunately, these are the children who die on the sidelines. There are fortunately now laws in all states about pulling children out of play if there's any suspicion of injury, to try to prevent any other children from a severe brain injury or death in that scenario. And then the next question, long-term recovery. I think what we know, and it's a common theme. I think that it's not the same thing for every child. So some of my work has looked at really studying children carefully after the point of clinical recovery. So they passed all our tests in clinic. We have cleared them to return to all of their sports and activities. They no longer have any symptoms. They don't need any accommodations in school. And we're finding that we can sometimes detect more difficulty with very subtle, rapid, repetitive movements, that sometimes the brain connectivity seems to be different. Some of our research is showing that maybe the first time we run children through something, we don't see anything different from peers who haven't had concussion. But when we repeat it a few months later, the children who didn't have concussion seem to have learned from that first exposure, and they're better, and their brains seem to be working more efficiently to complete the task. And the group of kids who had recovered from a concussion, it's like they never had that first exposure, that their brain isn't maybe as rapidly making those connections as Amy said, we're all doing. But it's not every child. And so I think that just really speaks to, again, continuing to get better and better at how we evaluate children individually. We spend a lot of time in patient care. A child soon after a concussion might see a pediatrician or a sports medicine clinic and have a quick 10 to 15 minute visit. We tend to see children who maybe aren't rapidly recovering in those first couple of weeks in our concussion clinic. And the first visit tends to be 2 to 3 hours because we really want to pull apart very specifically a lot of history about how was that child doing before the concussion, exactly what was the injury like, how are they recovering, how do we get them back to school in a very personalized way. And so I think really continuing to carefully characterize children, to learn like from the work that Adrian is doing in terms of who's at most risk for more problems down the road. And then, of course, we want to rehabilitate that gap. And then also bringing back genetics. I think that there has to be a role of genetics in how each child's brain responds to injury and how well they recover. I think this is why we have some former NFL players who have this phenomenon of CTE and some who don't, because they all had a very high load of injury to the head and probably their bodies were able to respond in different ways. And so I think that's what I would want everyone to take with them, is that we need to think about each individual and their recovery carefully and as an individual, and help guide families to make decisions for their individual child.
So I think we have time for two more questions. This next one I'm going to ask Amy to respond to. Can artificial intelligence identify patterns that humans miss, accelerate diagnosis, personalize therapies, and help rare disease?
The answer is yes, but definitely yes. AI is very good at finding patterns that connect very distant phenomena, albeit across modality, blood tests versus physical tests versus MRIs. But sometimes it can latch onto something that actually doesn't matter, even if it predicts. So if a child has ADHD, it might see in all the MRI scans that, oh, the best predictor of if you have ADHD is the kids who move their head in the scanner, which tells you nothing about the brain, but tells you that, they are different for a different reason. And some of my colleagues have told me these stories. But that being said, I think that the use of supervised versus unsupervised AI. So if it's unsupervised, the AI just goes out and finds all the things that seem to be doing a good job with prediction. We need them to be clinically meaningful to the patient, and really forwarding our understanding of the biology. And so not just using really unsupervised work, but also keeping in mind what we want from it and making sure it's biologically meaningful and perhaps hopefully actionable.
And so last question. I mean, there are tons more questions, so I'm sorry I can't get to all of them. I'm trying to capture the ones that sort of get at themes. And here's just a really cool question. Laura, maybe take a crack at it, but others can chime in. Do you foresee a future in which multimodal wearable sensing coupled with adaptive computational frameworks enables individualized modulation of rehab dosing based on continuously evolving estimates of patient-specific recovery dynamics? Laura, did you plant that question?
I did not. That is a complicated question there. But I think that, going back to a little bit what Amy had said, I think that there's a lot of uses and there's a lot of data out there, but it's about finding the meaningful patterns and the meaningless patterns that might exist as well. And so I think at the end of the day, this will all sort of be done by an algorithm? I think that there's a limitation to that, in all honesty, because I think one of the things that, if I got all parts of the question correct, I think one of the things that I would add to that as well is what is meaningful to the patient as well in terms of their recovery. And that's not something that necessarily, as we talked about before, technology alone is able to really integrate. That's where that human touch comes in. That's where the clinicians come in, and all the other work that we do to integrate all these different types of research. I don't know if anyone else has any responses to that as well.
Other responses? I'm not seeing any takers. I mean, I think it's a really important point that the technology may yield in that way, but the human element, the clinician contribution cannot be removed from the equation. And so we see, I think we all agree on this panel, that there will always be a need for the expert clinician. Expert clinicians, we talked about interdisciplinary approaches, using these tools, but not ceding clinical care to the tools. And I think that may be a good place to end a great discussion. And I want to thank our expert panelists for being here with us tonight and for sharing their insights on precision neurorehabilitation. Thank you as well to our audience for your thoughtful questions. So many excellent questions. I'm sorry I couldn't get to them all. And we hope that you found this webinar interesting, informative, and helpful. Likewise, we hope that you, as a supporter or friend of Kennedy Krieger, recognize and are proud of the major contributions that we're making to improve the lives of our patients and our community. Now, in the next few days, you'll receive a follow-up email with more information about the work that happens here at the Institute. In addition, you can visit our website at kennedykrieger.org, where you'll find ways to support us if you'd like, details about our upcoming events, and links to our monthly podcast, Your Child's Brain, which is produced by Kennedy Krieger with assistance from WYPR. Finally, we hope that you sign up for future webinars in our Exploring the Brain series. We are grateful you are here with us tonight. Thank you and have a wonderful evening.